Hello and welcome to the Imaging Wire Show. My name is Brian Casey. I'm managing editor of the Imaging Wire. We've got a great episode for you today. Our topic is mammography AI adoption, and we brought together two radiologists whose facilities are in different stages of AI implementation. Our guests are Dr. Shadi Aminololama-Shakeri. She is chief of the Division of Breast Radiology at the University of California, Davis, and Dr. David Forsberg of Mosaic Breast Imaging in Tennessee. David and Shadi, thanks so much for being with us today.
Thank you.
Thanks for having us.
You bet. So, Shadi, can you tell us a little bit about your role and your background in breast radiology?
Yeah, thank you for having us here today. I'm a dedicated breast imager. I'm fellowship trained, and I've been practicing solely breast imaging for over a decade at UC Davis in California. And I've been chief of the section for the past 7 years. And we have actually been working on adopting AI into our practice only for the past few months. And we've been evaluating using AI through the vision of our chair of the department, Dr. Elizabeth Morris, for a few months before that.
All right, very good. David, how about you?
Yes, I've been in private practice for a number of years, have been doing breast radiology exclusively for about a decade, and started Mosaic Breast Imaging about 2 years ago with the aim of providing excellent clinical quality in a very kind of beautiful, high-touch, high-service setting.
Very good. And you started using AI just recently, correct?
About 6 months ago. I believe AI is really an important part of our practice, and it continues to show its utility every day.
Very good. So let's just dive right in. So AI or mammography, breast imaging, has been probably one of the most interesting use cases for AI in all of radiology, and in particular breast screening. And so you both know the pressures that breast radiology practices face, but let's talk about that right now. Shadi, can you tell what some of the challenges are that your practice faces and kind of how you deal with some of those things?
Yeah, Brian, the challenges that we face in an academic setting, I feel like are almost universal, not just, in academic practices and private practices across our country, but I think even internationally. And that is one of a radiologist shortage. We are understaffed. And I think most practices in this country, if you could ask them if they could use more radiologists and more mammography technologists, the answer would be yes. And so that is, I think, by far the number one challenge that we face as a practice. And then what happens is the result of that is that the existing hardworking staff is experiencing burnout because of having to make up for the understaffing. And also at an academic practice, something that sets us apart is that this understaffing also affects our teaching and our research missions as well, because everyone is working so hard to meet the clinical needs of the practice.
Yeah. David, no, you're at a private practice. What are some of the challenges that you face?
Yeah, exactly what was just stated. But, trying to provide excellent quality services and deliver them in an expeditious manner. Dealing with the government and regulatory changes, reimbursement challenges. Mammography, those of us who do mammography full-time love it. Many radiologists do not. And AI is just a great tool to help us do our jobs better, and particularly perhaps those who are less confident, maybe general radiologists who do some mammography but don't do it exclusively.
Gotcha. Now, Shadi, on the clinical side, what are some of the clinical needs that are driving AI adoption in mammography? What are the clinical aspects that you would really like to get some help with?
I would say in breast imaging, a practice which has always been at the tip of the spear of radiology, it's always about finding better and better technologies to improve performance. And so we are always, as breast imagers, interested in raising cancer detection rates, decreasing our recall rates, increasing our positive predictive values for biopsies. And so what that would allow us to do by automating certain tasks and improving our performance, this allows us to have time to spend with our patients and have more in-depth discussions regarding their values, have shared decision-making, bring education regarding their risk levels for breast cancer, and what to do about it, such as supplemental screening and so on. So really, the clinical needs are to improve what we do already and use technology for that so that we can really affect patient care ultimately.
David, does that parallel your experience?
That's the bottom line. It's all about improving performance and doing a better job for our patients. There was a study that came out of South Florida from a group of very experienced breast radiologists. And AI, when leveraged with their expertise, resulted in increased cancer detection rates. And that's what it's all about.
Yeah. Well, what would you see, David? What would you like to see mammography do? You've been using it for a little while now. And when you began looking at AI, what were some of the things that you wanted it to help you do?
Improve performance first and foremost, and that remains the chief goal. And when I did an investigation of the literature across the world, it became very clear that AI was a game changer, particularly the European studies where they showed that you could replace the second radiologist, improve the performance of the radiologists. So that remains the chief goal. The old AI was sensitive, but not specific. It would help me maybe twice a year find calcs that were somewhat difficult to spot, but otherwise it flagged absolutely everything.
And so you had all these things it was flagging that you had to look up, right? You had to
you'd learn to ignore it, quite frankly, and rely on yourself and your experience. But modern AI and its present iteration and future iterations to come is much more sensitive and specific, or certainly specific than the old iterations. And so it's been extremely helpful. And it also helps increase the confidence of your reads, and it makes you more time efficient by triaging those cases that are normal.
Yeah. Now, Shadi, at your university, you're looking at implementing AI. What are some of the things that you hope that it helps you with?
Some of the things that I hope, in addition to what was just mentioned regarding, the growing body of evidence now showing that AI can be a possible replacement for a second reader. Things that I would like to see in an academic setting, for example, is in addition to getting better at what it does, perhaps there could be a development of an interactive component, teaching purposes. So, this is the first time in my career where I've had to rethink how to teach trainees how to read a screening mammogram, because you think about, well, am I going to teach it to them without an AI tool? Am I going to teach it to them with an AI tool? Each one of those things has its own consequences. And so I'd like to see AI actually develop some tools that would be helpful in teaching. Some of it could be interactive. Some of it could be, in a test environment where the trainees can actually test their skills and corroborate findings with AI. I'd like to see it be better than CAD was, and I think it already is, but I need that to be by leaps and bounds. So, for example, I would like to see when we read a screening mammogram, I'd like to see, instead of just perhaps a heat map or just an outline, I'd like to see it in a 3D volume rather than an outline of a large region, because all of that would become more and more accurate for us.
Yeah. Now, AI could do a lot of things beyond just image analysis and highlighting suspicious areas. It can do things like density analysis. It can do image triage. David, are these things important to you, or is that something that are you more focused on the image analysis aspect?
I'm mostly focused on the image analysis aspect. The density may have some utility, but that's less important to me personally. It's really more about the image analysis more than anything, and then the triaging of cases and increasing that confidence level and helping to sort out those cases that are normal or likely to be normal.
Shadi, how about you?
Yeah, image analysis really at this point in time is the most important thing. What I would like to see, I would like to see us go to a place where AI is able to provide patient level risk analysis to combine with that image analysis so that it can become really more of a holistic look at the image and everything that it can provide to the reader at one place, one time.
So, David, you started using AI at Mosaic in April, I believe. Can you talk about your experience with it and how it's changed your practice?
It's been really nice. It's been good to see that the practical implementation and daily utilization of the technology has mirrored what I've read about in the scientific literature. It has helped find cancers. It has, as I said, made us more confident in terms of true negative cancers. I use it on the fly, meaning I see all of my patients who come through here. And so the technologist will obtain the mammogram and then layer on the AI. And by the time the tech walks back into my office, I'm getting the AI superimposed on the mammographic images. So I read it real time. If the patient has dense breast tissue, they will get an ultrasound regardless of AI's findings. But AI sometimes will make us concentrate more intently on some areas of the breast than others. And I've got a great case that shows that.
Great. Shadi, can you tell us what's your status right now in terms of AI implementation at your university?
We have been, really looking at different AI tools for months and months. And we have started to trial it out in our clinical workflow for several months now. And so, we have a variety of radiologists who are starting to learn it, and we have some who are more adept at learning it. So we're at different stages of incorporating it into the workflow for all of our radiologists.
Let's talk a little bit more about workflow. So it's one thing to have the image analysis component, but AI can have a really big impact on your workflow, as we saw with CAD, where you're having to do, work up all these suspicious things. How important, Shadi, is AI's impact on your workflow to your university?
Well, I can tell you that it's really important. It's crucial that we are able to manage, as I mentioned earlier, the clinical volumes and the needs of women to have screening mammography. We want to be able to really provide and increase the usage of screening mammography to our populations. We are, for example, bringing in a mobile van to go to those communities in need. All of that means that there are more mammography centers that we're opening, more women that we're seeing. But without, with the circumstances of being understaffed, we need to get better at reading these exams in a timely manner. We want to be efficient, and we want to remain accurate, and the performance needs to stay high. For me personally, utilizing AI in our workflow, it's not about necessarily saving time, but saving my eyes. So I'm really interested in utilizing AI. I'm not interested in going from reading, let's say, 100 screening mammograms a day to being able to read 200 or 300 per day. I'm looking to be more accurate. I want AI to assist me to become a better breast imager and increase all those performance metrics that we mentioned earlier in the hour. And I want to have AI help me bring that patient who needs further investigation and then confidently let go of those who don't need it. So those are the ways that I would like to see it improve our workflows. AI can be good enough with data to support us so that we can replace some of the exhausting tasks that we perform as breast imagers. One of the areas that we at UC Davis are interested in investigating, for example, is to see whether we could replace utilizing AI to replace our tomosynthesis slices. We go through thousands of tomosynthesis slices, and you can imagine what that means for a radiologist's hands, scrolling through these, and for our eyes. So we want to utilize AI to decrease fatigue and overuse for radiologists. all with increased performance, of course.
Yeah. Are you going to be implementing AI for both 2D and tomo mammography?
We would like to. Again, this is all for us investigational at this point. So I would like to see that implemented.
Great. So, David, you're using AI for both 2D and tomo. Could you talk about that, and maybe also about how your use of AI has affected your workflow at your practice?
Yeah, we'll start with the second question first. It's improved the workflow. The key point here I think we're both trying to make is improved accuracy, finding more cancers. That is the marching order of AI and what we do as radiologists, and especially radiologists in particular. The side benefit, though, is it does make you more efficient. It does allow you to read more should you have the desire or the need to do so. Just because it's so easy now to triage those, normal patients, basically with AI risk scores of 10 or less. And so that's a huge benefit. I like the AI, and I'm using it on every case in both the 2D and the 3D images, and I've found it useful in both areas on different cases. I had one case, which hopefully you can show your readers, that had very dense breast tissue, some mild architectural distortion, not overly impressive. And then on the 3D tomographic slices, AI said there's an 85% chance of cancer right here in the medial aspect of this left breast. So this patient would have gotten a sonogram anyway. That's the way we practice. We do sonography or offer it for everyone with dense breast tissue. But I told my techs to zero in on this particular area because the Lunit AI, which is what I use, flagged it. And sure enough, there was a small cancer there.
Wow. David, do you think that, breast radiologists are kind of unique in that they seem to be the closest to patients of all the different types of radiologists. Do you see AI as freeing up radiologists to maybe spend more time with patients? Is that a possibility?
It's a possibility, but I think it also increases the confidence level of the patients in the process. It's funny. I added a note. We have a little form that patients sign if they want the AI, since it's elective in our practice. And I added a note saying, I strongly recommend this. Some people wouldn't want it because they didn't want to offend the radiologist, me, and my skill sets. But when you tell them, look, this is really important, it makes me better. And the research is substantive and vibrant. And, I really recommend that we do this. I've gotten a really great positive patient feedback and with the AI.
That's great. So we talked a little bit earlier about some of the research that's been backing up AI for breast screening, and some of it has been really profound. A lot of the studies coming out of Europe on double reading and that kind of thing. Shadi, do you feel like the existing research studies have adequately demonstrated the value of mammography AI, or do you think that there's maybe a little bit more that it needs to be proven?
I think that the growing body of data is really supportive of replacing that second reader, and I think it's showing that it is doing better than CAD did in the community of breast radiologists. I think that there needs to be more data, though. We're not quite there yet. I think we need to, across the board, be able to see AI tools which utilize comparison studies and can really start to mimic what a breast radiologist does. And that way, it becomes more accurate. It's not just a marking on a current exam, but it incorporates more information. And as I mentioned, by doing that, you can also come up with data regarding patient-level risk. And I think that's something that's very important for us to be able to go to. And I think that the technology can be improved. I want AI that has a stellar negative predictive value, meaning that when it's negative, I can really confidently let that exam go and not lose any sleep over it. And I'll tell you, the reason I say that is because there was an exam that wasn't marked by AI very recently, and thankfully had been in the recent months where I wasn't completely biased by the existence of the AI. And I did call the patient back, and it turned out to be a cancer. Now that's, a 1 in a million, but I need to have the confidence that when it's negative, it's truly negative, and I don't have to worry about it. So I think more work does need to be taking place.
In cases, it's just 1 in a million, but for that one patient, it's everything.
Exactly.
David, do you feel like AI is kind of proven itself in the literature, or would you like to see more studies done?
Yes and yes. I think the literature thus far is pretty compelling and pretty substantive, and some well-designed trials. Clearly, there's more work to be done. AI can be improved. It is not flawless, as we just heard. It's not ready to replace us, we radiologists, exclusively. It's an adjunct. So it's still very much a works in progress, but I would not be using it live clinically for all of my patients if it weren't ready for prime time.
Yeah. How do you judge success with AI adoption now that you've been using it for about 6 months now?
Yeah, that's a tough question to answer. Finding more cancers is the simple answer. I track all of my AI cases. I have a spreadsheet with breast density, the AI score, and I'll have more internal research as time goes on and as the years amass and I get more experience using it. So I think it's important to engineer some processes so that you can evaluate the performance of the AI and also your own performance of that AI and your decision-making processes. Early on, AI flagged something with a 80% suspicion rate. I did an ultrasound, found nothing. Given my lack of experience with the AI at that juncture, I did a breast MRI on the patient, and the breast MRI was stone cold normal. Okay, so it was a false positive. But I have been really very much impressed with its ability to flag abnormalities on the mammograms.
Very good. So Shadi, at your academic institution, you're in the process of implementing AI. Let's say one year after you've started using it, what would you like to have seen it do for you?
I'd like to see it improve performance by classic audit data. We breast imagers live and die by the audit data. And, it's at the individual radiologist level and group practice level. And I'd like to see all of that be improved by the adoption of AI. And I would like to see AI be able to help us improve our teaching mission. I want our trainees to become better because, let's face it, there aren't enough fellowship-trained breast specialists around the country. And so we would like to be able to train radiologists to go out there and be really, really good in their performance, reading, screening mammographies, utilizing AI as their assistant.
Yeah. So, David, we're about to wrap up. Any advice you have as someone who has been using AI in your private practice for a year, for 6 months now? Any advice you would have to somebody kind of in your position looking to acquire AI?
Do it. Do it tomorrow. Start the evaluation process. Seriously. I mean, why would you not want a tool that helps you find more cancers and perform your job better? So do not hesitate to implement AI in your practice. I think it's going to be absolutely ubiquitous in short order.
Very good. So Shadi, your institution has already made the decision to implement AI, and you're in the process of doing that. What sort of advice would you have for someone who is kind of looking to get into this?
I'll start by saying I have to admit that I was a little bit of a skeptic. And again, I'll mention that it was through the vision of my chair that we went on quickly to start adopting AI in our screening mammography practice. But I love it. I would say utilize it with very specific things in mind. One, always look at it at the end of the hanging protocol. Just like we did starting with CAD, utilize it as a second reader. And I would say don't abandon trust in your own skill set as a breast imager. Having seen what I've seen now for several months, I need to remind myself not to be biased just by the existence of AI in our system and continue to utilize my skill set that's been decades in the making and allow AI to help me improve that. One of the things I'll say, different radiologists have different needs. Some people want to triage their cases by what AI perhaps thinks may be positives in the beginning of their list. For me, just because of the way I practice, that would be detrimental. I'm one of those breast radiologists that needs to warm up. So if I do that and I have a bunch of positive exams in the top of the list, I actually will come back to them later when I've read a lot more of exams that are normals, and then I'll come back and evaluate the positives. So different people will use it differently, but one thing is for certain, that it is going to be, if it's going to be helpful to improving the performance of your practice, why not use it?
Very good. Well, the great words of advice. Dr. Shadi Aminololama-Shakeri and Dr. David Forsberg, thank you both so much for being with us. It's been a really great discussion.
It's been a pleasure to be here. Thank you for having us.
It's been my pleasure. Thanks so much.
You bet. Signing off for the Imaging Wire, my name is Brian Casey.